teachers and my colleagues. Today I'm going to present a very rare case of soft tissue tumor of female genital tract. This 19-year-old unmarried girl presented to casualty with abnormal vaginal bleeding since 3 months. Patient was apparently normal 3 months back when she developed excessive bleeding per vagina. Initially, the cycles were regular with increased duration of bleeding lasting for 7 to 8 days with history of passing clots. The duration and quantity of bleeding gradually increased associated with increased frequency. It used to last for 10 to 15 days and restart with a bleeding-free period of 3 to 4 days and restart again. The bleeding was heavy with passage of clots changing about 8 to 10 pads per day. She was admitted in a private hospital for the above complaints and received 6 units of blood in view of anemia. On admission, there is no history of easy fatigability or weakness. There was no history of pain abdomen, mass for abdomen, white discharge PD. There is no history of trauma or excessive weight gain or loss. There is no history of mass for vagina. Menstrual history. She attained menarche at the age of 11 years. The flow was regular. It was a heavy flow and lasting for 7 to 8 days. It was associated with pain and there was history of passage of clots. She was taking homeopathy treatment for menorrhagia since then. Past history. There is no history of tuberculosis, thyroid disorder, bleeding disorder, or there is no history of radiation exposure in childhood. There is no significant surgical, family, and personal history.
हो गया रे उसको माइक को थोड़ा मुंह का पास करो हो गया सब हाँ 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 ऑन है हाँ
On general physical examination, she was moderately built and nourished. She presented with mild pallor and no other significant findings in general and systemic examination. Her vitals were stable on the admission. On per abdominal examination, abdomen was soft and non-tender. There was no mass palpable. On per vaginal examination, one finger examination was done. A big polypoidal growth was felt in the vagina, most probably arising from the cervix. Finger could not be introduced beyond the upper extent. Mass was obliterating the vagina completely and vaginal walls were completely stretched out and free. There was profuse bleeding present. Clots along with foul-smelling friable tissue were removed. On per rectal examination, a big mass was palpable on anterior wall of rectum of variable consistency. It was non-tender. Mucosa was mobile over the mass, probably arising from cervix or body of uterus. The mass was compressing the rectal wall, obliterating the lumen anterior-posteriorly. On investigations, hemoglobin was 9 gram per cent and other parameters were within normal limits. On day 1, she was examined under general anesthesia and biopsy was taken from the mass and sent for histopathological examination. The findings were it was a polypoidal friable, scaly, vascular mass arising from the cervix circumferentially, occupying whole of vagina. The vagina was stretched out due to mass effect and the vaginal walls were tumor-free. Cervix could not be delineated from the uterus. A tight vaginal pack was given to control bleeding. Patient was transfused 2 units of whole blood as she was actively bleeding. The decision for laparotomy was taken on day 3 in view of uncontrolled bleeding. Total abdominal hysterectomy with removal of tumor in toto was done the next day. Per operative findings, uterus appeared normal in size and appearance. Both tubes and ovaries appeared normal. A big circumferential mass was felt at the base of uterus in the vagina. There was no extension noted in other pelvic organs. Total hysterectomy along with removal of whole mass with proximal two-thirds of vagina was done and both ovaries were preserved. On gross appearance, it was a huge polypoidal mass of approximate size 10 to 15 centimeters, seen originating from whole of the cervix, not involving vagina grossly. Multiple areas of necrosis and hemorrhages were present. On cut section, uterine cavity was around 2 inches, endometrium was grossly thickened, and cervix could not be differentiated from mass, but there was no extension of mass noted in the uterus. Patient received 2 units of whole blood post-operative. Histopathological examination of the operative specimen was compatible with botuloid variety of rhabdomyosarcoma arising from the endocervix, not invading ectocervix and the body of uterus. There was brisk mitotic activity. The microscopy appearance, tumor composed of nests and sheets of spindle-shaped round and oval cells with hyperchromatic nuclei and scanty cytoplasm lying in a myxoid stroma, exhibiting brisk mitotic activity. A cambium layer, which is a distinctive subepithelial dense tissue zone, was seen. Islands of cartilage were seen. On immunohistochemistry, the tumor cells express desmin and myogenin, which is compatible with embryonal rhabdomyosarcoma. The chest X-ray was well within normal limits. CT abdomen showed normal study. And on CT thorax, there was this tiny calcification in left perihilar region, and small hyperdense nodule was seen in superior lingual segment. On CT thorax, there was this tiny calcification in left perihilar region, and small hyperdense nodule was seen in superior lingual segment of left lung. Coming to the discussion part of rhabdomyosarcoma. These tissues include muscles, tendons, fat, blood vessels, nerves, and synovial tissues. Soft tissue tumors are uncommon in children and young adults. The incidence of soft tissue sarcomas for children and adolescents younger than 20 years of age was 11 per million, comprising 7.4% of cancer cases for this age group. More than 53% of these soft tissue sarcomas originate from the striated muscle and are called rhabdomyosarcomas, whereas 47% consists of a heterogeneous collection of subtypes referred to as non-rhabdomyosarcomas. Coming to rhabdomyosarcomas, it's a malignant tumor arising from immature mesenchymal cells committed to skeletal muscle lineage. Most commonly occurs in head and neck areas comprising 40%, genitourinary areas comprising 25%, and extremities comprising 20%. Bladder, vagina, and prostate being the most common sites in genitourinary region. Types of rhabdomyosarcomas, it's based on histology and called Horn and Enterline classification. It's classified into embryonal, alveolar, pleomorphic, undifferentiated, and undetermined. Embryonal being the most common, comprising 59.4%. Boteroid and spindle cell are variants of embryonal rhabdomyosarcoma. Coming to sarcoma boteroides per se, it was first described by Guerson in 1854. Pfannenstiel in 1892 commented on the grape-like appearance, hence the name boteroid in Greek. It constitutes 10% of all rhabdomyosarcoma cases. It arises under the mucosal surface of body orifices such as vagina, cervix, and bladder. Vagina being the most common site, it rarely occurs in cervix or uterine fundus. It's one of the most common neoplasm of the lower genital tract in girls under 16 years of age. It more frequently has a vaginal location in patients younger than 4 years, whereas cervical location has its peak incidence in the second decade of life. Although the sarcoma boteroides of the cervix has been reported in females as young as 5 months of age. Causes and risk factors. The exact cause has not been documented. However, majority do not have any known risk factors. Some families have a gene mutation that elevates the risk. It's associated with certain inherited syndromes like Li-Fraumeni syndrome, Beckwith-Weidman syndrome, and Costello syndrome. Clinical features are vaginal bleeding, sensation of a mass in the introitus. Embryonal rhabdomyosarcoma of the cervix usually presents as a cervical polyp or at times multiple polyps. The polypoidal mass are somewhat yellow in color, friable, that may easily break off, leading to vaginal bleeding or infection. In Hilger and colleagues report on 61 patients with sarcoma boteroides, 44.3% had a vaginal mass, 21.3% had vaginal bleeding, and 16.4% had both symptoms. Symptoms arising from areas other than the urogenital system are usually secondary to metastatic disease. On light microscopy findings, it's composed of rhabdomyoblasts and small round cells. Rhabdomyoblast, the more mature of the embryonal component, is characterized by bright eosinophilic cytoplasm. Rhabdomyoblast of varying differentiation is dispersed within a loose myxoid stroma. A distinct cambium layer beneath the epithelium is characteristic of embryonal rhabdomyosarcoma. Electron microscopy findings shows visible Z bands. On immunohistochemical analysis, skeletal muscle or muscle-specific protein like desmin, muscle-specific actin, and myodine are seen. Patterns of spread, it's mainly local spread to adjacent structures, regional spread via lymphatics, and distal spread via hematogenous route, most commonly to lungs, which is constituting 40 to 50%. Next is bones, CNS, liver, and breast. Majority have bilateral metastasis. Investigations like routine investigations have to be done. Next, biopsy of the tumor has to be taken, chest x-ray, CT chest, abdomen, pelvis, and bone scan to rule out metastasis. Staging, there are two types of staging. One is TNM staging and the clinical grouping system used by the intergroup rhabdomyosarcoma study, which is most commonly used because the whole management depends upon this kind of staging. Group 1, it is a localized disease, tumor that is completely removed with pathologically clear margin and there is no regional lymph node involvement. It comprises 13%. Group 2, it is a localized tumor that is grossly removed with microscopic disease in the margin, or it is there's regional lymph node involvement. Group 3, a localized tumor with gross residual disease after incomplete removal or only the biopsy has to be taken. And group 4, where distant metastases are present. Management, there are 3 modalities of treatment: surgery, radiation therapy for control of residual bulk or microscopic tumor, systemic combination chemotherapy for primary cytoreduction and eradication of gross and micrometastasis. In the past, less than 20% survived with surgery alone due to rapid metastasis. However, today more than 70% are cured with multimodal treatment. Excentrator procedures have often been used in the past. Hilger reviewed the literature on pelvic excentrate in 21 cases of embryonal rhabdomyosarcoma and found that this therapy is ineffective in curing these patients. Principles of surgical management: complete resection of the primary tumor with surrounding margins of uninvolved tissue during the initial surgery has to be done. If microscopic residual disease is found after resection, re-excision is indicated before any kind of non-surgical management. Clinically involved lymph node should always be sampled. In case of complete resection is not feasible, initial biopsy followed by neoadjuvant chemotherapy and definitive local control measures should be done. Debulking procedures have no value as initial biopsy and neoadjuvant therapy results in shrinkage of the tumor, allowing complete resection at second look operation. This is better than partial or marginal resections. Principles of radiation therapy. According to rhabdomyosarcoma study group protocols, all rhabdomyosarcoma should get radiotherapy to achieve long-term local control of tumors as it can eradicate residual tumor cells. IRS-4 study report that seems to suggest that pulmonary radiotherapy does provide some benefit. For gross residual disease and for tumors more than 5 centimeters, 4,500 to 5,000 centigrade is used, and for residual microscopic disease, 4,000 to 4,500 centigrade is used. Intracavitary and interstitial brachytherapy are useful techniques. Principles of chemotherapy. Patients must receive combination chemotherapy as there is ample evidence that the adjuvant or neoadjuvant therapy significantly improves survival. The chemotherapy should begin soon after the diagnostic studies of primary excision has been done, as the major role of chemotherapy is the eradication of microscopic foci of disease. Neoadjuvant therapy, chemotherapy reduces the unresectable tumors to resectable size. The current gold standard chemotherapy regimen for sarcoma botryoidis or embryonal rhabdomyosarcoma is VAC therapy, which is vincristine, actinomycin D, and cyclophosphamide. Other agents that can be used are ifosfamide, doxorubicin, and etoposide. Prognosis: 5-year survival rate for rhabdomyosarcoma is 90% for stage 1, 80% for stage 2, 70% for stage 3, and 30% for stage 4. Sarcoma botryoidis of cervix fare better than that of vagina and uterus. 5-year survival rate for sarcoma botryoidis of cervix is being 5 to 35%. Metastasis is the single most important predictor of clinical outcome. Hilger and colleagues reported that the following factors appear to favor the prognosis: minimal delay between the onset of symptoms and operation, superficial involvement in the vagina without local extension,